I will be talking about ectopic ACTH dependent Cushing syndrome. Let's go through this from a perspective of a lesson learning process. I'll be talking about the ATPA presentation and approach to diagnosis, some tackling of opportunistic infections, false localization, why size does not necessarily matter, occult disease, prolonged medical treatment, and delayed and secondary presentations. So just for the broadness of this audience, we knew that pituitary disease is the most important cause for ACTH producing tumors. Having said that, there are a number of conditions which might result in ectopic ACTH producing syndrome. And essentially, they include bronchial carcinoid, malignancies of the lung, thymic carcinoid, pancreatic tumors, medullary thyroid cancer, pheochromocytomas, and occasionally you may not find or get a definitive cause. So let's first talk about the ATPR presentation, an approach to diagnosis, and how we tackle opportunistic infections. This is a 19-year-old medical student who presented with hypertension during screening for medical admission in August 2012. He had hypertension and was asymptomatic for the next 3 months. They thought it was white-collar hypertension, left it alone. Subsequently, he had weight gain for over 40 days, high blood pressure recorded at 160 by 100, swelling of the lower limbs, facial puffiness, and other features of Cushing syndrome in addition. So progressive weakness of the lower limbs, bedbound since the initial part of the year, severe hypokalemia, lower backache, and psychosis. There was polyuria and polydipsia found to have high sugars, and he was started on insulin 1 week prior to coming to us. Initially, his potassium was extremely low, and he had severe hypokalemic alkalosis. So the first kind of question that one would ask is, what is the type of Cushing's that this patient has? This is a young male with hypertension, diabetes, rapidly progressive symptoms, and gross hyperpigmentation with severe hypokalemia. Therefore, with this constellation of severe hypokalemia and very rapid progression of symptoms in a young male, this combination would make us think of an ectopic ACTH producing Cushing's. This is his appearance, dull, apathetic, got generalized pigmentation, and his blood pressure when he came to us was just borderline. And therefore, what would one do at this particular point of time? So we go through the process of screening for Cushing's in this very obvious clinical case, and we find that the cortisol levels are elevated in the basal state, the midnight cortisols are elevated, and both post-low dose and high dose cortisol levels are not suppressed. In fact, they're extremely high. The urine-free cortisol levels are also sky high, almost something like 100 times the upper limit of normal. And the ACTH levels are well above the cutoff range in our lab, are almost 20 times the upper limit of normal at 696. So this patient had initially come in and had an ACTH measured. The initial physician had saw him and asked for an MRI of the pituitary, thinking, of course, this must be the commonest cause. But what the MRI does show is a slightly bulky pituitary, and one should go into looking at an MRI in an objective sense. So when we look at the pituitary, one would apply the Elster staging, and the minimally convex upward look, almost spherical look, is seen in grade 4 and grade 5, which might indicate a pathological lesion. Now, this is a bulky pituitary, but having said that, there is no definite focal lesion. This is the CT of the abdomen. Now, considering that the high dose is not suppressed, the high dose dexamethasone suppression test, we thought this was an ectopic ACTH producing syndrome. The CT abdomen shows bilateral hyperplastic adrenals, very large, bulky adrenals. And objectively, how do you figure out whether this is enlarged or not? Well, there are Indian studies and one done from our center, which have shown that the average size of an adrenal gland is larger on the left than on the right, and is larger in males when compared to females. Well, this is almost 4 times the normal size of a normal adrenal gland that we saw in our patient. As you can see over here, bilaterally hyperplastic adrenal glands. The CT thorax was also done, and this shows a bulky lesion in the anterior superior part of the mediastinum. So this was followed up by a Dotenok PET scan, which showed an anterior mediastinal soft tissue lesion, which is in the location of what would be the thymus, and is possibly the site of an ectopic ACTH producing tumor. So the patient was subjected to a thymectomy by the thoracic surgeons. A total thymectomy was performed, and the thymus was found to be adherent to the innominate vein, and the tumor in the left lobe of the thymus was dissected, and the left phrenic nerve was preserved. So after the surgery, he did not have remission. There was persistence of hypokalemia, hyperglycemia, hypertension, and edema, and the ACTH levels were also elevated. So for all patients with Cushing's, obviously, you need to have a lifelong follow-up. This patient, because of his aggressive, persistent disease, underwent a bilateral adrenalectomy shortly later. And you can see over here, a week after surgery, this is his sternotomy site. You can see on the chest X-ray, he develops cough and fever, and you can see infiltrates which are dominant on the left side of the lung. Now, of course, this could have been a run-of-the-mill post-operative respiratory infection, which he could have had. But having said that, this might be something else. So the differential diagnosis that one needs to think about over here are a pyogenic pneumonia, nocardiosis, pneumocystis carinii, and tuberculosis. Now, you should think about acute opportunistic infections in this kind of a situation, particularly if there's disproportionately fever is not significantly elevated. So nocardia and pneumocystis carinii are particularly important to think in this sort of situation. The patient was started empirically on norepinephrine and on trimethoprim sulfamethoxazole combination, and these medications were continued. In the meantime, within 3 days, we actually got through the bronchial lavage neocardial species which were present. Filamentous gram-positive organisms were picked up on the smear. This is his subsequent X-ray done 2 months later, and he is asymptomatic. So in Cushing's, we need to keep the index of opportunistic infections very high and treat empirically fast and first. That's really important because otherwise one might succumb to these opportunistic infections, and I'll show you data as to how important this is. Our patient had, for his residual ACTH producing thymic tumor, chemotherapy. He was given temozolomide, an alkylating agent, along with capecitabine for the residual tumor. And this is his progressive photographs. As you can see, he still comes to us for follow-up 9 years later, and he's doing pretty well. Now, this is our experience of ectopic ACTH Cushing syndrome, which has been published in endocrine practice a few years back. And we did compare them with controls of pituitary Cushing's to try and see how they would differ clinically as well as biochemically. And what we can see over here is that the frequency of central obesity is actually much less. In ectopic ACTH, they do not have central obesity as a major presentation. It's only around 14%. They are much more florid in their hardcore clinical features of Cushing's, like easy bruisability. Pigmentation is much more florid. Edema is also much more prominent than those with pituitary Cushing's. And what was really striking is that the likelihood of developing opportunistic infections is very, very high. Almost in pituitary Cushing's, by and large, it is not a major presenting feature. Biochemistry is very dramatic. Baseline cortisols are elevated. ACTH is invariably extremely high, usually much more than 100 picogram per ml in our lab. The midnight cortisols are elevated, and the urine-free cortisol levels show absolutely or virtually no overlap with those patients who have pituitary Cushing's. They're extremely high once again. So if you have a good UFC assay and a good ACTH assay, these can actually help in you predicting your possibility of ectopic ACTH versus Cushing's syndrome before doing the high-dose dexamethasone suppression test. Remember, the high-dose dexamethasone suppression test may not be suppressed in about 15% of patients who have pituitary-dependent Cushing syndrome. Because they have a highly catabolic state, the serum albumin is also extremely low. And of course, as I mentioned to you, they have hypokalemic alkalosis as well. So here's another patient, an 18-year-old who came with a history of bloody diarrhea for 2 years, evolution of Cushing's features over just 2 months, biochemically high ACTH, cortisol, and UFC, which were all in the range of what might be an ectopic ACTH. We evaluated him in detail and even did a PET scan, but did not find anything. So therefore, occult. Now, when he came to us, he came with this bloody diarrhea, and a CT of the abdomen showed, of course, the adrenal hyperplasia, but also showed a large hepatic fluid-containing spaces, which were basically abscesses, and an aspirate and a blood culture showed an odd organism called Advesella tarda. Now, you get all these kinds of exotic infections, and the reason for this is this gentleman had gone fishing about 2 weeks before, and this is a microorganism found in fish usually, and not in humans, but in a human with Cushing's, this can be pretty much dangerous. The next lesson I'm going to talk to you about is about false localization. Here is a patient once again with features of Cushing's, acne, generalized swelling, diabetes and hypertension, and biochemistry once again, which is pretty classical. High UFC, extremely high UFC levels, which are reminiscent of ectopic ACTH and high ACTH levels as well. Now, this patient had actually had an MRI outside, which was actually the red herring. The red herring in the sense that you can see 2 microadenomas on the MRI on either side of the stalk. And this, if you remember once again, the other patient whom I'd shown you also showed a bulky pituitary, the first patient whom I just talked to you about. The patient at another center underwent a transsphenoidal surgery, but the biopsy was not suggestive of an ACTH secreting adenoma, and his cortisol levels persisted to be high. Now, this basically patient came down to us, and the biopsy was reviewed, and it was suggestive of nodular hyperplasia and not a pituitary tumor. The reticulin fracturing was not present. So he had a persistent hypercortisolemic state. The DOTA PET done at our center showed a lesion in the parenchyma of the lung, which is pericardiac, and this indicated the possibility of a bronchial carcinoid over here. So this patient underwent bilateral. Now, the patient, in fact, was given the option. We, in fact, told him there's a possibility, yes, we can go ahead with the lobectomy of the lung, but he said, no, I want a guarantee for a cure. We negotiated with him for almost 2 or 3 weeks, and finally he decided, if you're not going to cure me, and if you think there may be a malignancy in my lung, or it's a slow-growing tumor, which may not be totally removable, then I'd like a total cure. And we went ahead with an adrenalectomy. This is a little unusual based on the patient's request, but this is what we pursued finally, and primarily eradicated Cushing's. He has been on follow-up thereafter, which has shown a lesion which is very similar, present in the lung, and persistent post-operative serial ACTH levels show a more or less persistent elevation. He last came to us for follow-up in 2019, and he remains otherwise asymptomatic other than showing some pigmentation due to the ACTH levels. Now, a pituitary MRI in this situation is always a difficult proposition. You can get a bulky pituitary or you can get nodular changes because of concomitant CRH secretion. Many of these patients who produce neuroendocrine tumors that produce ACH may also produce CRH in addition, and this can be responsible for the nodular changes. And CRH is generally not a measurable hormone in most labs across the world. In fact, we sent our sample to Oxford, and they were not able to actually find this, but they said there's possibility of CRH lurking around, which might be causing the nodular changes in the pituitary in this situation. The next lesson is size does not determine the severity of a neoplasm. 29-year-old gentleman with recurrent episodes of acne and muscle weakness, hypertension for 4 years before he came to us. He was given diuretics elsewhere, all kinds of treatments were given, even had a workup for Cushing's before he came to us, which was negative. And Then, when we saw him, his cortisol levels were elevated. High UFC again, and ACTH levels which were extremely high. So this patient once again had a pituitary outside, lo and behold, which was normal, a pituitary MRI, and it was possibly, we thought, a Rathke's cleft cyst, and the CT abdomen showing hyperplasia of the adrenal and a thymic mass. So patient had a total thymectomy, hard 4 centimeter mass infiltrating the walls of the superior vena cava, and this was stuck to the pericardium. And here you can see there was a thymic neuroendocrine tumor. The ACTH immunostaining was present as well, and this patient essentially had a thymic carcinoma. Patient had carboplatin-based chemotherapy and relapsed in 2 years' time. Subsequently had lutetium therapy after DOTA PET scan was still shown to be positive, but subsequently had progression of disease and death after 2 doses of lutetium. So what does our series on ectopic ACTH show? There's a male predominance of 5:2. Thymic and bronchial carcinoid and lung carcinomas are a dominant cause, 17 out of 21, 80%. So basically, and 19 out of 21 therefore have the etiology above the diaphragm if you add on medullary thyroid cancer. The CT thorax or a PET CT clinches the diagnosis in 80% of cases. All thymic carcinomas have local metastasis at diagnosis at diagnosis or after surgery in our series, and there is a 50% recurrence of lesions in our patients who had bronchial carcinoids. Our next lesson is that of occult disease and our story of prolonged medical treatment. 55-year-old man came way back in 2006, generalized edema, swelling of the face and body, pigmentation. He had ecchymosis present, features of Cushing syndrome, and his potassium was extremely low. I remember this gentleman, he came in and he was very refractory to treatment. We gave him 40 grams of potassium infusions per day for a total number of 3 days. We had given him spironolactone for 300 milligram for a week, and his ACTH levels were very high. His imaging at that time was normal, and in 2006, we did not have PET scanning in the institution. Medical treatment was considered as an option. He was given ketoconazole initially, but developed hepatitis. And therefore, we reviewed the possibilities. Of course, these are centrally acting, which do not work in ectopic ACTH. We thought ectopic ACTH because of his severe disease, hyperkalemia and alkalosis. We thought of drugs which might work peripherally, but the ketoconazole option was abandoned because he had hepatitis. So we finally opted for something we had used in the past a lot, and that was mitotane. Mitotane, of course, is feared by a lot of physicians outside, but in our experience, the doses you give for Cushing's are much less than what you give for adrenocortical carcinoma, where you need huge doses of 4 to 8 grams. But in these situations, you can manage with doses of less than 1 to 2 grams per day. So clinically, he was started on mitogram 2 grams per day, and he has been followed up for the last 15 years. He's had 2 FDG PET scans, which are negative, 2 DOTA PET scans, which have been negative, and he's asymptomatic on mitotane therapy. So our experience is that with ketoconazole 200 to 1200 mg per day, we have an 80% response. There are patients who are refractory or become resistant to ketoconazole, and then we use mitotane treatment in those situations. Finally, delayed and secondary presentations is what I'll be covering. 67-year-old man with the typical features of Cushing's, but also had weight loss of 10 kgs for 3 months. He had episodes of palpitations and panic attacks and a sense of impending doom. Known hypertensive, diabetic for a long duration of time, but had also been on antihypertensives for increased doses for a year, and had a right adrenalectomy for a pheochromocytoma 2 years before. He had a carcinoma glottis, which is unrelated, and underwent a cordectomy at that point of time. So you can see high blood pressure, severe proximal myopathy, no hyperpigmentation, bruisability or stria, but weight loss. Biochemically, once again, hypokalemia, grossly elevated midnight cortisol, very high urine-free cortisol, and very high ACTH levels with high urinary norepinephrine levels. So what could this be? Sources: recurrent pheochromocytoma with ACTH production, newly emergent malignancy because he's had a previous vocal cord malignancy. So could it be a new lung malignancy or a carcinoid or something else? Yeah, this is the FDG PET, which shows the surgery on this side and multiple lobulated small discrete enhancing lesions in the right suprarenal lesion and a diffusely enlarged enhancing left adrenal gland. Severe disease, unfit for surgery. Consider medical treatment. So we started him on intravenous edomidate, and this resulted in some degree of improvement. Also started on alpha-adrenergic blockers and taken up for bilateral immediately after weeks. But he was found to have, unfortunately, diffuse peritoneal metastasis at laparotomy. And here you can see chromaffin stains, and they were also positive for ACTH. Diffuse spread of disease, only one adrenal was removed at the time of surgery, and we planned for an MIBG treatment because he was MIBG positive. He needed etomidate, mitotane, ketoconazole postoperatively, all in combination, very refractory, and finally died of pneumonia as well. So similar experiences with late onset presentation in 3 patients with medullary thyroid cancer with 100% mortality, unfortunately. So let me summarize. Ectopic ACTH dependent Cushing's have a more severe clinical and biochemical phenotype compared to pituitary disease. Supradiaphragmatic disease is present in 85% of patients. Local metastasis is almost invariable with thymic disease. Opportunistic infections are common and need early and aggressive treatment. Medical therapy is effective as bridging treatment before surgery or for long-term treatment. Early adrenalectomy, a very important lesson preceding definitive primary tumor removal, is a frequent thing that we do because it can prevent severe acute morbidity. Thank you for your patient listening. I'd like to acknowledge my entire department, allied departments who have helped us with treatment, endocrine surgery, nuclear medicine, biochemistry, and radiodiagnosis.
And that was a very wonderful talk, justice done to a very difficult time in 15-20 minutes. And it just tells us about the spectrum of this disorder, biological as well as clinical. Couple of questions, Nihal. You talked about that first patient who had a thymoma, and in that there was a tumor. If that was surgically removed and still had some features of Cushing's, means either the surgery was not adequate or tumor possibly was elsewhere. You need to do the bilateral adrenalectomy. Your comments on that?
Yeah, thank you, Dr. Zargar. The problem is that most of these patients have local metastasis, and they have adhesions to the vasculature in the lung, notably the venous vasculature, and so the brachiocephalic vessels, etc. And so they are usually very difficult to resect in these situations. So it is local metastasis which we are dealing with in these patients, which is a big challenge. And of course, therefore, we have to subsequently resort to chemotherapy and, of course, early adrenalectomy once again for remission of the Cushing's per se.
Good. About that fourth case, where you went into pituitary a couple of times and then ultimately it proved to be a carcinoid. One thing that needs to be understood in the current times, given the accuracy of current imaging tools, you will have many pituitary incidentalomas. And when you have a setting like that, you might think there's a pituitary tumor from which ACTH is coming. It may not be coming. And there is data which has shown up to 8 to 10% of cellular radiology done for trauma, if reviewed, might have an incidentaloma in the pituitary. So that part should be also understood, that there might be an OR case that might explain that situation in your case number 4.
100%, Dr. Zargar. The fact is that the patient had these procedures done elsewhere before coming to us. And I'm certain that in most reputed institutions nowadays, they'd be very cautious in interpreting an MRI in these situations. 10 to 15% of MRIs will show something. And particularly here, remember that these ectopic ACTH producing tumors co-secrete CRH along with the ACTH. And therefore, a swelling in the pituitary could always happen.
Absolutely. Ganpati has a comment or two.
Yeah, actually, just to talk about the thymoma thing, we have had, of course, not presenting as Cushing's, but then the most important reason, thymoma are very aggressive tumors, and they have a malignancy rate of up to 70%. So that's one thing with the thymoma. Did you think about men or something like that? Had you done a workup for men?
You're right.
In there?
So we, in fact, in all our patients with thymoma, we always look out for MEN1 as a potential possibility. These 4 out of the 5, I think 4 patients did not have MEN1. One patient eventually had a family history of MEN1, but this was the index presentation, and subsequently there were no other occurrences of any other features of MEN1 in those patients. We have had, of course, most of the, so that's it about the patients with thymomas who have MEN1. The MEN1 presentation from another site will be actually prominent. For example, GH-producing adenomas is something which we have seen with greater frequency, and of course, hyperparathyroidism.
Yes, hyperparathyroidism, yes. Yeah, well, how about in the medical line, what about your experience with mifepristone?
Yeah. So the problem, as you know, with mifepristone is actually monitoring these patients after giving them mifepristone. It is very difficult. It's a challenging thing, especially since very often what you're trying to do is achieve borderline control in these situations. When you go up to maximum doses of ketoconazole, or if you use mitotane, you reach this point of borderline. And we use the urine-free cortisol actually for monitoring these patients because it's very useful. Now, with mifepristone, you have a problem with monitoring these patients and trying to figure out whether they're truly in remission. You can go clinically, but that's really not enough because some of these vague symptoms that they have, like diabetes or hypertension or whatever, are not necessarily, they may or may not remit, and you still are in a quandary as to whether. So we haven't really used mifepristone in our armamentarium because of our apprehension. I'm not saying that you can't. You could always give it a try, but this is our basic issue about monitoring these patients long term.